Thanks again for joining us for our virtual forum today. She Recovers, Navigating Unique Challenges for Women in Addiction Treatment. We are pleased to introduce our presenter, one of BrightView's lead advanced practice providers, Brianna Ramseur. Brianna?
Hey, everybody. I'm super excited to be here today. My name is Brianna Ramseur. I've been a nurse practitioner for the last 8 years. I've been working with BrightView for the last 2.5 of those. Definitely have tried a lot of different things as a nurse practitioner, but found my calling in addiction medicine. I feel really strongly about the work that we do. And I'm just really excited to be able to share some of the things that I've definitely learned over the last couple of years and things that are specific to women. Today, we're going to cover a couple different things. We're going to discuss some of the medical and clinical factors that are really specific to women. We're going to talk about some external impacts that we need to consider when we're walking through addiction treatment with women, and just an overview of some of the things that we can do to make sure we're providing effective treatment for women. Next slide. So when we look at medical and clinical factors that are unique to women, it really is more than just treating a substance use disorder and alcohol use disorder. We have to really look beyond that and look at women's health in general, because all of those things are going to be impacted by substance use disorders, alcohol use disorders, but also just in general having access. Next slide. So the CDC does always, help us a lot in terms of giving us some of the statistics related to health concerns. According to the CDC, for women specifically, about 15.6% of women who are older than 18 rate their own health as fair or poor. And so these are pretty broad surveys that are done where people are asked to rate their own health. And so women are saying that about themselves, that they're in fair or poor health. About 8.8% of women who are under 65 don't actually have health insurance coverage. And so this has a huge impact on both access to treatment for substance use disorders, but also for just general medical coverage. The leading causes of death for women are going to be heart disease, cancer, and stroke. Those are our top 3. And all of these are actually linked to substance use disorders as well. And so use of alcohol, use of substances is definitely going to increase the risk for that occurrence in women. And so these are things to really consider as we walk through treatment with them. Looking at some of the statistics about overdose deaths, which, definitely over the last 20 years, we can see that there's been this sharp incline. If you look at this chart that's over on the right, really had a tremendous climb in overdose death in both men and women. In the last few years, we're starting to see that very gradually trend back down. We're hoping to see that trend down even further as we increase access and are able to really help men and women navigate treatment. In terms of alcohol use disorder, looking at CDC statistics, the CDC actually defines binge drinking as the consumption of 4 or more drinks in one day for women. And we see that about 19.8% of women who are 18 and older in the last year report binge drinking at least once. And so we definitely want to consider that when we're talking to women about CDC recommendations for what is considered safe alcohol use and what is considered to be excessive alcohol use. Next slide. So some of the concerns from the National Library of Medicine, looking at just primary health concerns, definitely heart disease and cancer. Cancer involves both female-specific cancers, so ovarian cancer, uterine cancer, and cervical cancer, and then also cancers in general. Definitely mental health disorders, mood disorders, which occur in a higher rate in women than in men. Dementia and Alzheimer's, autoimmune disorders, osteoporosis, some gynecologic and reproductive health, and diabetes. And we're going to talk through a couple of those because some of those are impacted by both substance use and the treatment. And so we want to definitely talk through some of that. Next slide. When we think about co-occurring disorders in females, certainly there are some gender differences that are co-occurring when we look at co-occurring psychiatric disorders. So women are much more likely to experience a traumatic event and develop PTSD prior to using substances, prior to the onset of a substance use disorder. Women often with a dual diagnosis of PTSD and substance use disorders have been the victims of childhood abuse and are vulnerable to repeated traumas in adulthood. So screening for those things and making sure that we're addressing those with women actually will improve outcomes for people that are seeking substance use disorders. And really just being aware that this happens more often in women can just help us stay in line with that and make sure that we're offering services that are going to support them through that. Lifetime rates for mood and anxiety disorders are significantly higher among women than men. And that's including women that don't have a substance use disorder. So we just see that overall that happens more often in women. But certainly when we look at substance use disorders and see that co-occurring disorder, we want to make sure that we're in tune with women and know that that's the case. Eating disorders are actually very common. About 40% of women with a substance use disorder also have a co-occurring eating disorder. And so this is certainly something that we screen for and something that we want to make sure we provide resources for. When we look at anorexia and bulimia, we see that 90% of those cases actually occur in women. And so we definitely want to be lining that up when we're looking through assessments and trying to provide resources for them, because when they are successfully treating one, they're actually more successfully going to treat the other as well. Next slide. So this is actually pretty fascinating. So when we look at how women are impacted by substance use disorders, biologically, there are, of course, differences in hormones and metabolism. This often can lead to more problems, even when somebody is using a similar or less amount and using less frequently. So women do often experience what's referred to as telescoping. Telescoping is where you have a rapid progression from the time that you first use a substance to dependency to an actual substance use disorder. And so we see that happens much more quickly in women than in men. And so women are more likely to go from first use to a substance use disorder in a really rapid progression. And so we have to make sure that we are teaching people that one, and that we're considering that when women talk about short-term use, that their likelihood to develop a substance use disorder is much higher. Psychologically, we do see higher rates of physical and intimate partner violence in women, certainly sexual assault and post-traumatic stress disorder. And so that typically is something that is happening before the onset of a substance use disorder, more commonly in women, but also things that happen after and can definitely inhibit success in treatment. And so we want to be screening for those things routinely. From an environmental perspective, we just see that women seek care less often. For every 2 men that enter treatment, only 1 woman seeks care. This can sometimes be the result of financial dependence, lower rates of insurance, and increased childcare responsibilities. And we're going to talk a little bit about those, but those are just definitely things to consider as we look through the impact that is specific to females. Next slide. So the social stigma is definitely something that is different with women than men. Certainly overall, we have a huge social stigma that we hope to overcome in regards to substance use disorders and alcohol use disorders and their treatment. But a lot of times in women, this is much more pronounced. And so women who are using alcohol and illicit drugs often experience heightened emotions of shame and guilt, so at a much higher level than we see with men. And they have lower levels of self-esteem and self-efficacy. So they a lot of times will not really believe in themselves. That's really more what we're talking about with self-efficacy, is that they don't believe that they can be successful in treatment. And this often leads to them avoiding treatment or not engaging fully in treatment or not being successful in treatment. A lot of times they're devalued or they face disapproval by other women. When I was looking through this, my first thought was women are a lot of times a lot meaner to other women than men are. And so that's certainly something that we see happen and can often cause them to avoid treatment because they don't want to acknowledge that to other women. Relative to men, women who are in treatment consistently report more severe functional impairment, both with employment within their social circles and within their family, and certainly with medical and psychiatric functioning. And so those are things that we definitely want to be looking at as we walk through this with patients. Next slide. So some gender-specific barriers. This is really what I think is important. I mean, all of this is important, but this is what I think is important in terms of reducing barriers to treatment for women, is looking at some of the obstacles that can be very specific to them. So low socioeconomic status is certainly one of those. We see that without resources, women are just not always able to engage. Certainly there's a higher likelihood of single parenting or being the sole caregiver and not having a support system. A lot of women lack childcare, and so they aren't comfortable coming to a clinic, or they don't feel like their children are welcome in a clinic, or they're just not able to leave their children. Certainly if they're the sole caregiver for their children, getting to treatment can be really difficult. And so we want to make sure that we consider that we create environments that allow for women to seek treatment with their children, which we know definitely improves their outcomes, and that we're considering that as a barrier. Definitely, we've talked a little bit about the greater incidence of trauma and violence. And this can sometimes make it to where women do not feel comfortable or trust services that are being offered to them. Definitely in certain situations, we see triggers for PTSD when engaging in treatment. And so this becomes really important for us when we look at trauma-informed care and making sure that we're accommodating those needs for women. Definitely the societal stigma of substance use, a lack of affordable or safe housing, a lack of transportation. Some cultural barriers are definitely going to be more specific to women, a feeling of shame or embarrassment, not wanting to share when they're struggling, or being too proud. And so we definitely see that, want to speak to that, want to make sure we're engaging women in overcoming that. And then sometimes just the lack of awareness, not knowing what treatment is available, or not knowing what the benefit of treatment would be. And so being able to educate on that when women come in, being able to educate in the community for those things, so that we can get women to engage in treatment is certainly really important for us to be looking at. Next slide. So some pathology that's really unique to women. When we look at sociodemographics, we see that they play a huge role in retaining women in treatment. And so there are studies that suggest that when we have the support and participation of their significant others, that women stay in treatment longer and have better outcomes. Older women tend to stay in treatment longer than younger women, and having at least a high school education seems to be a really protective factor that improves retention for women. And so we definitely want to help support building those things up, definitely engaging with family involvement, involving significant others and participation in treatment, to help support just those things that we know are protective factors. Justice system involvement or child protective service involvement is also associated with longer lengths of treatment. So women who are coming to treatment either through the court system with CPS, they're more likely to stay in treatment. Being reunited with children seems to be highly motivational and helps for women to both engage in treatment and stay in treatment longer. And then definitely women are more likely to stay in treatment if they've been successful in other areas of their life, or if they're really confident in the treatment process and the outcome. So this happens a lot of times when women have seen other people engage in treatment and be successful, or if they've been successful in other areas. So when we see women get jobs, when we see women that have, been reunited with their families, that they start to be successful in those areas, and then they engage in treatment in a more meaningful way that helps them stay in treatment longer and have better outcomes. Next slide. So pregnancy specifically can be really challenging. I think that with women, this is probably where we see the most stigma, where we see people really start to struggle. One of the things to consider is that individuals who are the highest risk of developing a substance use disorder are also categorically in the age group of people most likely to get pregnant. And so we see that that risk is there. And then we see that that occurs fairly frequently. So about 3.6% of pregnant women meet the diagnostic criteria for alcohol use disorder, and about 1.6% meet the diagnostic criteria for substance use disorders. This is based on criteria from the DSM-5. And so when we are interviewing patients and assessing these things, this is not an uncommon occurrence. But it is often underreported. So a lot of women who are pregnant do not want to tell you that they're using. This can be the result of shame and guilt. It can also be the result of fear. Certainly most women do not want to report that they're using while they're pregnant, especially if they have other children, for fear that their children are going to be taken away or that they're going to be in legal trouble. And so being able to have an honest conversation where we tell women the truth about, criminal justice involvement, CPS involvement, but also where we create a really protective environment where they can be honest so that they can be treated appropriately is super important. A lot of times we'll see pregnant women who either don't utilize basic gynecological services, or they delay really finding out about their pregnancy. And then they either delay or completely avoid prenatal care because of their substance use. This is a very common occurrence where women come in and we are asking them, hey, have you followed up with OB? And they're saying, no, definitely not. I'm waiting until I have a negative drug screen, because of the fear of both judgment and the fear of consequence. And so it's really important that we make sure that we're having those conversations about how important it is to set up with high-risk OB. Certainly while we're in treatment, we want to encourage that so that we're keeping moms and babies safe. Next slide. So there's such a huge opportunity in pregnancy for us to really educate and intervene, to be able to talk to women about, methods for safe treatment, and definitely to discuss the positive outcomes that occur when we treat substance use disorders during pregnancy. There's certainly statistically an improved maternal and fetal outcome when substance use disorders are treated during pregnancy. But one of the big fears that we run into is kind of this idea of withdrawal when babies are born. And so neonatal abstinence syndrome is certainly treatable. It's not associated with long-term adverse consequences, but there's just a huge stigma around it. And so making sure that we're teaching moms that, it's safe and it's recommended for them to be treated during pregnancy while still being honest about some of the potential risk is really important. But avoiding the stigma is going to be one of the most important things that we do. So having that discussion that newborn babies are certainly not born addicted, that word seems to be really stigmatizing, and it's also highly inaccurate. And so making sure that we talk about them, having a dependency, having, neonatal abstinence syndrome is really more of a medical diagnosis that can be treated, and having them follow up with a high-risk OB who knows how to treat that and can keep their baby safe really does seem to help moms engage in treatment in a way that's really helpful for them to be able to be successful. Certainly, we want to avoid portraying their babies as victims, and creating kind of this idea that moms are villains who are hurting their babies, and are perpetrators, which really just kind of furthers the idea that, their addiction is criminal, as opposed to the idea that, they're struggling with a medical disease and that we want them to be healthy and safe. Next slide. So when we look at some external impacts for women specifically, this is so important because we kind of forget sometimes that substance use disorders, while there is a genetic component that we can see, there are certainly a lot of external impacts that can result in developing a substance use disorder or that perpetuate the substance use disorder. And so we want to make sure that we're staying on top of, education for ourselves and making sure that we're screening appropriately. Next slide. One of these is going to be the role of intimate partner violence. This is not an uncommon occurrence. So we see that about 41% of women experienced physical violence, sexual violence, or stalking by an intimate partner in their lifetime. So, that is not a small number, and this definitely has a tremendous impact on both the development of substance use disorders and alcohol use disorders, as well as, the continuation of substance use and alcohol use. About 1 in 3 women have experienced some form of intimate partner violence, and about 1 in 10 women have been raped by an intimate partner. When we look at women who have been stalked by an intimate partner, about 10.7% of women have been stalked. And for overall female stalking victims, about 66.2% of overall stalking occurs by either current or former intimate partner. It is really hard to get a lot of people who have experienced this to engage in medical treatment. And so only about 34% who are injured from intimate partner violence will receive medical care. And there's also tremendous impact in our homeless communities. So about half of the women who experience homelessness identify intimate partner violence as an immediate cause. And so they are not able to be safe in their homes, and it results in homelessness. Next slide. So also the role of sexual assault. These numbers are just staggering and discouraging, but about 464,634 victims of sexual assault. This happens this many times in the United States every year. So these are specifically people who are age 12 years and older. About 1 in 6 American women have been the victim of an attempted or completed rape, and 90% of adult rape victims are female. So this is happening to women more often than it's happening to men, and is definitely a key factor in developing substance use disorders and alcohol use disorders. Victims of sexual assault are 3 times more likely to develop depression and 6 times more likely to suffer from PTSD. They are 13 times more likely to develop an alcohol use disorder and 26 times more likely to develop a substance use disorder. And so we certainly want to consider and be screening for these things, because when we treat PTSD and depression, when we help create plans for trauma counseling, we do see more successful outcomes for both alcohol use disorder and substance use disorder. And so it's important that we be looking at some of these external factors. Next slide. So as far as the connections between relationships, these are some other external factors that are going to impact substance use disorders. So things about shared drug use that are important. Women often view shared drug use with their partners as a means of connection or relationship maintenance. And so we see that a lot of times if women are with men who are using, they are more likely to be using. And so it's something to consider in discussing partners and social relationships. As far as just some of the gender dynamics, male partners often initiate rituals around drug use. And in romantic partnerships, men are often responsible for obtaining, purchasing, and injecting the drugs for women. And so sharing needles or using drugs with a sexual partner might create this feeling for emotional closeness for women. But it also can indicate that there's an imbalance in power in the relationship. And so we do consider those things. It is important to note that women do face higher risks of HIV and AIDS and hepatitis due to needle sharing or engaging in sexual relationships with drug injecting partners. And so these are things we certainly want to be screening for and understanding that women are at a higher risk for that. Next slide. As far as relationship status, marriage seems to be protective against substance use disorders. Women who are separated, never married, or divorced are at a greater risk for substance use and developing substance use disorders. However, it is important to consider that this is not always the case. And so we want to make sure that we're looking at social relationships and talking through some of those things. Relationship status does continue to influence treatment beyond just getting people into treatment. And so it can significantly impact treatment engagement and whether or not people continue. So breakups, makeups, continued use by a significant other can often induce feelings of guilt for seeking help, or their partners will make them feel guilty for abandoning them to seek help. And so we do see that there's kind of a tremendous impact on healthy relationships versus toxic relationships that may impact continued use or might inhibit somebody from seeking treatment in the first place. Next slide. As far as family history and relationships go, women are more likely to define themselves in terms of their webs of social relationships and obligations. And so they do consider how, one action here will impact 5 other relationships that they have. And that can a lot of times impact their levels of anxiety and stress. But it also does often define how they see themselves in terms of engaging in treatment and what that's going to look like within their family. It does often happen that they report having had alcoholic parents, alcohol dependent parents, or other alcohol dependent relatives and dysfunctional family patterns if they have also been diagnosed with an alcohol use disorder. So women typically see that association. My parents had alcohol issues, I have alcohol issues, whereas men don't often identify it that way. And it's also more likely that they will be introduced to and initiate alcohol and drug use through significant relationships like boyfriends, spouses, partners, and other family members. As far as what we can do to help with that, one of the things that we certainly want to do is explore the acceptance of their substance use among their family and significant relationships. We want to ask questions about how their family relationships impact their engagement in treatment, whether or not their family wants them to stop using, and definitely look through whether or not people in their house are using themselves. We definitely want to discuss concerns regarding childcare needs and the type of support that they've received from family or their spouse for entering treatment. It's really interesting to see that dynamic. A lot of patients will say, oh, I have, tremendous social support and they're very successful in treatment. They have lots of help with their kids. Their family's highly motivated, versus the other where they, seem to really be guilt tripped and you don't care about your family because you're doing this and it's selfish and it's just for you. And so you want to explore that with women, let them have space to talk through that, make sure that they certainly have the support that they need and the resources that they need. You definitely want to talk to women about the different caregiver roles that they may have. A lot of women are taking care of their parents and taking care of their children and taking care of their spouses. They may have other people that they're providing care for. And so you want to explore that with them. A lot of those are going to cause tremendous social stress. We want to make sure that we're offering support where we can and creating an opportunity to provide resources where we can. And then certainly we want to review the parenting history and their current living circumstances so that we can offer resources there as well. Next slide. So this was actually one of my favorite parts of this discussion, is about children as an incentive versus children as a barrier to treatment. So women are much more likely than men to enter treatment because it affects child custody. And so we see that as an incentive, right? Women are more likely to engage in treatment because of child custody issues. If they can have their children with them during treatment, women are more likely to enter treatment, stay in treatment, and be abstinent. So a lot of programs, residential programs specifically, that allow for women to have their children with them during treatment, women are much more successful in those programs. And so that is definitely seen as an incentive. Likewise, women with children in treatment have better treatment outcomes and also better outcomes in major life areas in comparison to women who are without their children. And so women in recovery often see the support of their children as essential. It's one of the most important parts of their recovery. However, it is important to consider that children can be a barrier to seeking treatment because of lack of childcare. And so not being able to, engage in treatment because they don't have somebody to help with their children. And also the fear of retribution or having their children taken away. And so a lot of women will avoid treatment until it's forced on them because they don't want their kids to be removed from their homes. And that's definitely something to consider when we're exploring these caregiver roles with women. Next slide. So this is really where we're going to dig into some of the ways that we can provide effective treatment. Next slide. So if you look at how many people do not engage in treatment, so about 43% of women who are 18 or older with any mental illness, and this includes also half of youths who are 12 to 17 with a major depressive episode, did not receive any treatment within the past year. And so a lot fewer women sought help for substance use disorders, and 32.3% of women with co-occurring substance use disorders and any mental illness did not receive treatment. So we have a large group of people that are not engaged in treatment. And that number actually can really be read up to 90% that don't receive treatment. So we have a lot of barriers that we need to overcome, and definitely the stigmatization of substance use disorders that we need to really be educating and helping overcome in our communities. Next slide. So to be able to engage women in recovery, one of the things that we have to do is really offer the resources that they need. Gender-specific therapy groups are really important. Certainly, if you have women who have experienced sexual abuse or trauma, we want to make sure that we have opportunity for them to engage in a way that feels safe for them. Definitely educating our staff and making sure that we're providing trauma-informed care is super important. Having therapeutic relationships that are really consistent with counselors and case managers. Consistency and trust is really important for patients. I hear very frequently from patients, once they've told their story to somebody and developed a bond with them, they don't want to continue to tell it over and over. And so being able to have that consistency and trust that they don't have to repeat themselves over and over is really important. Offering dual diagnosis treatment is certainly going to be helpful for having somebody engage in treatment, and definitely offering resources. If that's not something that a center is able to provide, being able to help them engage with mental health follow-up is certainly going to help with better outcomes. Pregnancy and parenting support. I know for me, I tell people it's okay to bring your kids to a medical appointment because I want to make sure that we are never creating a barrier where we don't have to have one. Family therapy options, building social support, helping people learn emotional regulation skills. These are things that are going to help with just long-term success, both in treatment and at home. And also encouraging realistic expectations. It is not uncommon for people to engage in treatment and to think, I just need a week or two to get myself right, and then I'm not going to have to come back here. And making sure that we're educating people on a realistic expectation for treatment, for their life, for their dependency and substance use disorder. We want to make sure that we're being honest with people. And then ongoing monitoring and evaluation, making sure that, we're walking alongside people as they go through this process. Next slide. So when we look at approaches for women, these three are really important. They can be effective on their own, but also in combination with one another. Certainly, trauma-informed perspective is super, super important. Trauma-informed care is the responsibility of everybody who interacts with the patient. So this goes beyond just your counselors and your care coordinators, and certainly goes into medical providers, our MAs, our PSRs, people who answer the phones for us, making sure that we're, providing trauma-informed care is everyone's responsibility. Certainly screening and assessing for trauma and PTSD on the first visit. We can't stress this enough. This is so important because so many women have some type of trauma that is triggering or fueling their addiction. And so making sure that we're assessing for it and that we are, providing resources to help them address those things is just essential to success in recovery. And then proactively treating their trauma instead of waiting for something to occur. So instead of waiting for a crisis, making sure that, we screen appropriately and offer resources immediately is so important. A strengths-based approach to treatment. Strengths-based approach involves helping people really build up the things that they're already good at. This helps with both self-esteem, it helps them develop resiliency, helps to deepen their sense of confidence and confidence. And so people are much more motivated when we focus on the things that they already feel good at. And so this can include, basic personality traits, telling somebody that there are good things about them and really focusing on those. Their abilities, their knowledge, their cultural values, spirituality, and making sure that as we kind of go through these, that we really build people up and tell them, hey, you have all of these great things about you, and we want you to help those things get even better, and, kind of allowing for them to build that self-esteem. And then, of course, maintaining a gender-responsive treatment environment. So for women do better in a collaborative environment where they're nurtured and supported, and where people empower them. And so we want to make sure that, we're treating women that way, giving them that sense of empowerment, and then creating a support system in our treatment plan, which can include group therapy and healthy client and clinician partnerships. Making sure that patients are really involved in their own treatment development is super important. But specifically for women, being collaborative with women is essential to being successful because they really need that in order to be able to engage treatment deeply and be able to make sure that they're able to be successful in hitting the goals that they have for themselves. Next slide. So some women may be so used to higher levels of stress that when life is settled, they might experience a sense of boredom or feeling uncomfortable, sometimes experience feelings of being down or depressed when they stop using alcohol and drugs. This is very, very common, but it's one of the things that we have to kind of know about, that a lot of times this can lead to relapse where we see somebody get really, really settled and then they're just kind of bored and uncomfortable and not sure what to do with themselves. And so we want to really engage treatment approaches that are going to be supportive and that are going to promote connections with other people in treatment and relationship, because that will a lot of times help keep them focused. And then one thing to consider just as far as gender responsive treatment principles, women with substance use disorders typically are being referred either through self-referral, criminal justice system, or child protective services. And so we want to make sure that, we're kind of looking at how did you get here and make sure that we're meeting those goals with them in a way that's really specific to them. Next slide. As far as relapse risk goes, for alcohol, relapse rates are actually similar across men and women. And so when we look at women, one of the things that is different for alcohol use disorder is that marriage and marital stress are risk factors for alcohol relapse. But among men, marriage actually lowers their relapse risk. And so one of the things to consider is that women with an alcohol use disorder are more likely to be married to men who have an alcohol use disorder. And so they're at risk for relapse because they are also with somebody who has an alcohol use disorder, whereas men with an alcohol use disorder are more likely to be married to a woman without an alcohol use disorder. And so marriage in that way is a protective factor for them. And these are things to consider when we interview patients and we ask them, who lives in your home? Do they drink alcohol? Those are the things that we're considering, is how do we keep people safe? And how do we reduce their risk for relapse by creating some protective barriers for them in their homes? As far as women who relapse with substance use, one of the things to consider is that they appear to be more sensitive to negative effects. So when they feel emotionally distressed or when they're having interpersonal problems, women are more likely to relapse on substances. So this can involve things like unresolved trauma, social or environmental issues, having stress or poor coping skills, not having a good support system, feeling overconfident or complacent about their treatment, a lack of continued services or aftercare plans, or having just an unrealistic expectation or feeling hopeless. And so we see that women can be really sensitive to these negative things. Men, on the other hand, and this is not always, but this is more often, are more likely to have a positive experience prior to relapse. So I refer to that as the celebratory relapse. Men are more likely to have something good happen, and in response to that, use substances. And that's not always. Men, of course, are impacted by negative effects, but definitely something to consider is that women are much more sensitive to those things. So that's kind of just the broad overview. Next slide. I think we're kind of to the Q&A portion.
Thank you so much, Brianna. We are going to go ahead with the Q&A portion of today's discussion. Feel free to drop any questions you may have in the chat, and we will get to as many as we can. To kick things off, Brianna, what is one thing attendees could share with other providers who might be skeptical about utilizing MAT with women and how it might improve their lives or their family life?
One of the most important things that I think we have to consider with women is that when we engage in treatment, specifically medication-assisted treatment, that we are also opening opportunity to address all kinds of other medical concerns. And so when we improve their access with substance use disorders, one of the things that we certainly do is offer resources. And so we reduce all-cause mortality in women by more than 50% when we engage them in medication-assisted treatment. And so you definitely want to consider not just the impact that we have on substance use disorders, but also the impact that we're having on women's health overall in opening up that opportunity to engage them with a primary care provider, with their OB or their gynecologist, and other specialists that they may need to see. And so that's certainly one of the things that I encourage other providers to do, is to really engage in kind of expanding our view beyond just substance use disorders into the real benefit of engaging in treatment overall.
I know we talked about this a little bit, but could you maybe remind us or highlight some key takeaways of specific considerations that we could use for treatment during pregnancy and postpartum care?
So there is kind of an art to treating women who are pregnant who have substance use disorders or alcohol use disorders. Certainly avoiding anything that's stigmatizing. It's such a huge barrier to treatment, feeling like they're being judged or like they're not good moms if they're struggling with substances. That can be so challenging for a woman who's pregnant. So it's really, really important for us to always tell people, check your bias at the door. Like, you cannot come into that. You have to be really aware of your own bias and make sure that that's not being brought to the patient, because it's just not going to be helpful. Certainly with treatment, there are some things to consider medication-wise. One is that the use of methadone and Suboxone are both indicated for pregnancy. We certainly want to encourage women not to cold turkey off of opiates, as it can increase their risk for fetal demise and miscarriage. And so we want to engage people in treatment. We want to talk about those things and just being smart about the medicine. A lot of women, as they progress in pregnancy, when they get into their third trimester, they do start to have withdrawal symptoms or cravings. And we want to make sure that we're encouraging them to adjust their medication as appropriate, so that we make sure we're keeping them safe from relapse, and also that we're keeping them safe from a harm reduction standpoint if they do relapse. And so those are definitely things to consider. Getting anybody who is on methadone or Suboxone, getting them with a high-risk OB provider is just essential, so that they can be safe, so that their babies can be safe. We want to make sure that we're helping facilitate that, so that they're getting where they need to get to.
In a similar vein, we had an attendee ask a little bit more about neonatal abstinence syndrome. Given what you said about NAS, does that effectively debunk the messaging that we've all heard for decades, that babies are born addicted? Could you talk a little bit more about the long-term outcomes of NAS? How do we treat it? What does that look like?
Absolutely. So there are actually very few long-term outcomes from neonatal abstinence syndrome. So when babies are born, who have moms that have been on Suboxone or methadone, certainly the risk is there. It's typically treated in the hospital over the course of a few days, and babies are weaned off of opiates while they're in the hospital. And there's not a significant long-term effect from that. That being said, there are some things to consider, and we do not ever use these to kind of choose for moms which medication to use, but just of note that moms who are on Suboxone are actually less likely to experience neonatal abstinence syndrome than moms who are on methadone. But certainly either form of medication-assisted treatment is appropriate. And certainly, there are times where Suboxone may not be possible, and where we would need to use methadone, and methadone is certainly safe for us to do that. But just to kind of note that, to know, okay, we really want to make sure that mom is prepared for this as a possibility. But as far as long-term effects from neonatal abstinence syndrome for infants, there's not really anything to speak of that we would tell moms to be concerned about.
This is another question from an attendee. Could you speak a little bit about why there might be less treatment centers, halfway houses, and programs for women versus men, especially women's and children's shelters?
I don't honestly have a great answer for that. I think a lot of it is probably money related. If I'm honest, it is expensive to house women and children. And so a lot of times when we're needing to house women and their children, we just see a lot more barriers. Men, I think, are more often going to engage solo. And so having a house that's available for them is probably a little bit easier than arranging all of the resources that you would need for a woman and her children. There are a lot of resources, and there are more all the time. I know that, even just where I live in Tennessee, they're building new houses that are specific for, domestic violence, and shelters for women that are also going to address substance use disorders. And so I think that there's definitely the need that is being seen there. It's going to take some time to create all of the resources that we need for that.
Absolutely. You mentioned Suboxone and methadone. Could you talk a little bit about long-term methadone treatment and its effects on women's health as they age?
So one of the things that you will certainly see if you get online and you Google, long-term effects of methadone on women, certainly you see this interruption in the endocrine cycle. I know I always joke about how much fun it is to say this, but the hypothalamic pituitary gonadal axis is certainly impacted by the use of long-term methadone. And so you do see women that may have fertility issues, that may have bone density issues, that may experience menopausal symptoms earlier than we would expect. Those things do happen. However, it's really important to note that those same things also happen with the use of heroin and fentanyl. So this is not necessarily specific to methadone. And so when we consider whether or not it is a good choice for somebody to start methadone treatment to be able to stop using heroin and fentanyl and other full opioid agonists, we definitely want to be educating people on that. We want to make sure that, we're being honest about the potential risks associated with using methadone, but also that we're smart in considering whether or not continuing heroin and fentanyl use versus using methadone and having some stability and safety in treatment is a better option. Definitely, we want to be looking at, the cardiac risks for women as they get older. Women have an increased cardiac risk as they age. And certainly the use of methadone can prolong the QT interval. We monitor for that. Specifically, we monitor with an EKG. And so we don't want to ignore that as a possibility. We want to make sure we're educated about that. There are certainly risks anytime we take medication, but we want to make sure that we're making smart choices. And so we monitor those things. We educate, women on those things so that we're all keeping track of it. And so that when women start to experience those things, that we're smart and fast and help.
Another question from an attendee says, CPS considers babies who are born with drugs in their system as victims of physical abuse, and that mothers are considered perpetrators of that. How can we address stigma within those entities and our communities?
That's such a big question. And I may get myself in trouble for the way that I answer it, but I'm going to be just really upfront with people. I think that is unfortunate. And the reason that I think it's unfortunate is because I think that as a society, we have not really appropriately addressed substance use disorders as a medical diagnosis. But CPS does not take away gigantic children from diabetic moms who don't watch their diet while they're pregnant, because we consider gestational diabetes as a medical process and the effects on the baby as just a part of a medical process that's outside of a mother's control. And I think that the best way that we can address stigma is by being really direct and really honest about it, and identifying substance use disorders as the medical disease that they are. That's hard to do. It's hard to do. We have a huge society of people that are really negative and sometimes even hateful towards patients who are suffering. And so, education is certainly key. We want to make sure that we're educating people and providing resources to help them. The goal overall with pregnant moms is to help them be healthy and to help their babies be healthy. And we can't do that if we create, villains and tell them that, they're bad moms. So it's just my opinion. That's the way that I would teach it, but it's hard to
Could you talk a little bit about your experience treating women of color? What can we do to increase access to treatment and develop trust in more urban communities?
So one of the things that for me is really helpful in treating people of color is in acknowledging some of the differences in their experience. Unfortunately, people of color have not always had a great experience in the medical community. And as much as people might want to deny that or ignore it, when we do, we actually further that distrust. And so creating some open space for people to be honest about their experiences with the medical community, sometimes even their experience within their communities as a whole, not just engaging in medical, but allowing some space for them to talk about that and for us to be really open and good listeners and to, make sure that we're offering resources appropriately, and to avoid, using any kind of stereotypes or generalizations when we're going to be treating people of color is so important. And so I think a lot of times the mistake that I see made is that people just aren't good listeners, or they want to make sure that they are telling people their experience instead of listening to their experience. And so overall, I think it's just really valuable to create space for people to talk about their lived experience, and then to make sure that we are supporting that patient to overcome those things and those barriers that they've encountered before, to create an environment where they can trust that we care about them and want to make sure we take good care of them.
Could you discuss any challenges faced by pregnant women needing access to residential treatment?
Yes. So residential treatment that is not specific for pregnant women is a lot more common than residential treatment that is specific for pregnant women. A lot of people who are running residential treatment centers will not feel comfortable being able to provide the medical care that a pregnant woman would need. And so that creates a barrier there. There are treatment programs that are specifically catered towards women who are pregnant, and those can be so helpful and so useful for helping somebody get sober and be safe while they are pregnant. But the barrier really becomes pregnant women who already have children. That's one thing that I see really specifically, is that you'll have somebody who's pregnant that also either have a small child that they're caregiving for, and being able to get to residential treatment that way is also a huge barrier. And so it's a matter of really finding the right place. They exist, but they're hard to find, especially in rural communities. So we don't see it as often in a lot of the rural environments where you have pregnant women who have substance use disorders or alcohol use disorders. And so finding a place is the biggest barrier, I think.
Are there any differences in how those who offer support to a female patient versus a male patient can help foster improvement in the patient's self-worth? Or if there's any other insights you have on treating male versus female patients, we'd love to hear it.
There's a really interesting book that I promised myself I wasn't going to mention, but now I'm going to mention it. It's a book called Women Are Like Spaghetti and Men Are Like Waffles. And so one of the things that they say in this book that I thought was just fascinating is that women have to feel good to be good, and men have to do good to be good. And just kind of knowing that sometimes, and that's obviously a huge generalization, but a lot of times women, when you're speaking to them, having that positive reinforcement, having that kind of build of self-esteem and self-worth actually will help them be much more successful. Whereas for men, a lot of times acknowledging their accomplishments is actually more important to them. And so you kind of see that when you're supporting somebody through recovery, that, you know, men may be more focused on their actual accomplishments in recovery, whereas women may be more focused on how they're feeling and how their family relationships have improved through that process. And so you really just want to engage in whatever you see for that patient is going to really help them kind of next step navigate through the recovery process.
This is another question from an attendee. Are there any treatment models that you know of that address older female patients? They've seen a lot of changes in the age of women seeking substance treatment over the years, and today they have a lot of patients over the age of 60.
I'd be lying if I said yes. I don't know a specific treatment model that addresses women who are older than 60. But certainly I think that's something worth looking into. I do see that we have, and I think that we're going to continue to see a lot of people who are in treatment for longer periods of time, and definitely that are going to be engaged in treatment in that 60, 65 plus age range. And so I think it's certainly worth looking into. I think that's something important that we should be doing.
And then we will end on a good one. Are there any last reflections or recommendations for providers in private practice working with women with SUD that you would recommend?
So just in general, if I'm honest, I think that the most important thing that we can do for women is to just listen. A lot of women that are coming into treatment have been told what they're going to do. They are told what to do by their families, by their, you know, parents, by their children, by their husbands, by the court system. And so as a provider, to explain to somebody like, hey, I'm teaming you 100% of the time. And so when you come here, my job is not to tell you what to do, it's to tell you what you can do, and to let you decide what you want to do. And so that is, in my mind, the best advice is to let patients really drive their own care and their treatment, and to just be that support next to them that says, hey, these are all your options. This is everything that you can do. And to let them guide that. I think that's probably the most important thing that you could tell a provider to do.